Thank you for the opportunity to speak today. My name is Sagi Dain, and I'm a clinical geneticist and OBGYN specialist at Carmel Medical Center, Haifa, Israel. My talk today will focus on the genetic evaluation of fetuses with intrauterine growth restriction. So IUGR or FGR, fetal growth restriction, involves 3 to 10% of all pregnancies, depending on the definition. The majority of the cases are of late onset and are diagnosed at over 32 weeks of gestational age. About 90% of pregnancies with IUGR have no associated sonographic anomalies. So this is one of the common cases that are referred to prenatal genetic counseling. A young, healthy woman with an isolated late-onset IUGR following normal prenatal follow-up. She wants you to explain whether she should perform an amniocentesis and what would be the recommended genetic testing. I have to know that in Israel, termination of pregnancy can be performed at any gestational age in accordance with specific criteria. From gestational age of 24 weeks, termination of pregnancy requires approval of a designated board and only for very selected criteria, including high risk for severe neonatal or childhood morbidity or mortality. So genetic counseling due to late onset isolated IUGR is pretty common in our country. There are hundreds of genetic syndromes associated with IUGR, some of which are illustrated in this slide, such as Russell-Silver syndrome, trisomy 18, and others. The latest ECHO practice bulletin on the issue of IUGR notes that at least 50% of pregnancies with trisomy 13 or 18 have IUGR. However, the specific woman with IUGR might not be interested in the rates of IUGR in fetuses with chromosomal anomalies. What interests her is mainly the risk for genetic disorders in her specific fetus with IUGR. I have to tell you that in the last 6 years, we have published numerous articles describing the risk for clinically significant microarray findings in the various sonographic anomalies. These studies were based on the database of the Ministry of Health, since any invasive testing by CMA performed due to abnormal prenatal sonographic findings is reported to and financed by the Ministry of Health. Unfortunately, the recorded data are pretty limited and include mainly the indication for invasive testing, maternal age, gestational age, and CMA result. For each sonographic anomaly, we have calculated the rates of clinically significant pathogenic and likely pathogenic CMA findings and compared these to a control cohort. The control cohort consisted of over 5,000 pregnancies with normal follow-up, including normal ultrasound and normal maternal serum screening. In this group, a baseline risk of 1.4% for clinically significant CMA findings was noted. By the way, during the analysis of the database, we discovered that the clinicians can be very creative when it comes to the spelling of the words horseshoe kidney. So it was interesting to note that for the majority of these anomalies, the risk for abnormal CMA results was not increased compared to normal pregnancies. Only 3 anomalies were associated with a significantly increased risk. Would you like to guess which? These were moderate to severe polyhydramnios, right aortic arch, and clubfoot. Anyway, when my colleagues suggested me to examine pregnancies with IUGR, I did not agree to do it, and in the next several slides, I will explain why. You see, IUGR is nothing like a horseshoe kidney or a heart defect. It's a dynamic anomaly, and the risk for genetic problems in pregnancies with IUGR depends on numerous factors. First, it depends on the definition of IUGR, which is not uniform. The percentiles to define IUGR differ. Some include only the estimated fetal weight, while others also refer to abdominal circumference, and some also take into account Doppler measurements. Associated sonographic anomalies obviously increase the risk for genetic disorders. However, their detection might depend on the experience of the sonographer and the quality of sonographic equipment. In addition, the risk for genetic disorders is obviously related to the results of screening tests for common autosomal trisomies, the gestational age, and the correct dating, symmetrical versus asymmetrical IUGR, Doppler measurements, and singleton versus multiple pregnancies. Finally, the risk depends on the method of genetic testing, which obviously affects the detection rates, the control cohort, and other confounders. Let's dive into the literature evidence exploring the risks for genetic problems in pregnancies with IUGR. First, let's speak about karyotype or microscopic chromosomal examination. Actually, it was our 2017 systematic review which described the available evidence on the detection of gross chromosomal aberrations in apparently isolated IUGR. 14 studies were found, encompassing 874 pregnancies and yielding a risk of 6.4% for abnormal karyotype. However, the review had numerous limitations. For example, the definition of IUGR differed widely between the studies and wasn't mentioned by about half. A confirmation of the correct dating was performed only by 3 studies. Only 1 study confirmed low risk for Down syndrome. Only 2 studies examined late onset isolated IUGR, encompassing 32 pregnancies and yielded normal karyotype in all cases. Thus, the quality of evidence was defined as very low. What about the risk for abnormal microarray findings in pregnancies with IUGR? So I didn't have to work hard here, as Borrell and colleagues have published an excellent meta-analysis in 2018. The author described the 10 studies encompassing 376 pregnancies with isolated IUGR. They showed that the incremental value of CMA was 4%, significantly increased over that of karyotype. However, did the included studies refer to the numerous confounders? Let's look only at the 2 largest studies by Schaffer and by Borrell. So in 2012, Lisa Schaffer and colleagues described CMA results in almost 3,000 pregnancies with abnormal ultrasounds and normal karyotypes. Of the 115 fetuses with isolated IUGR, 2.6% were diagnosed with abnormal microarray results. However, obviously this large study, which examined numerous sonographic anomalies, did not refer to the specific definition of IUGR, the dating, or other confounders. The second largest study by Borrell et al., published in 2017, described 7 abnormal CMA findings in 114 cases of IUGR, isolated. These authors specifically focused on fetuses with early growth restriction. They described pregnancies with fetal weight below 3rd percentile, estimated earlier than 32 weeks, with a normal QF-PCR result. You can see that the 7 cases with pathogenic copy number variants included a isolated IUGR, as well as 3 fetuses with non-structural anomalies. And here you can see the description of these non-structural anomalies. In our country, many of these are considered an indication for invasive testing by themselves, such as VSD, clubfoot, ambiguous genitalia, etc. Still, this study presents nice evidence for increased risk for abnormal CMA in pregnancies with severe early onset IUGR. So finally, in our study, in which I was not the primary investigator, we tried to examine the risks for microarray anomalies in pregnancies with IUGR, aiming to take into account multiple confounders. 2 cases with abnormal CMA were found in the cohort of 59 fetuses with isolated IUGR, which is 3.4%. This was not significantly different from the baseline risk. The 2 abnormal results were trisomy 21 and 17q12 microduplication. It must be noted that the maternal age and the results of maternal serum screening in pregnancy with the trisomy 21 were not reported. so possibly we had to exclude this case from the calculation. In non-isolated IUGR, the risk for abnormal CMA was over 12%, significantly higher compared to the baseline risk. It was interesting to know that the risk for abnormal CMA in IUGR fetuses with cardiac defects was 75%. However, you have probably noticed that we had only 4 fetuses with cardiac defects, which is a very limited sample size. Regarding the timing of the diagnosis, no abnormal CMA findings were noted in fetuses diagnosed with IUGR after 26 weeks, as opposed to 13% in earlier onset IUGR. Similarly, no abnormal CMA results were noted in fetuses with mild IUGR over 5th percentile. However, this group had only 19 fetuses. Only 1 abnormal result was noted in IUGR between 3rd to 5th percentiles. And finally, no abnormal microarray results were noted in 27 pregnancies with Doppler signs of placental insufficiency. This seems to make sense, but again, this is a very small cohort. You can see that similar to previous studies, we were not able to refer to many confounders. In addition, some of the subgroups were implausibly small. The authors came to pretty obvious conclusions that CMA should be performed for pregnancies with early onset IUGR or with major structural anomalies. The results of exome sequencing in IUGR were described by 2 recent meta-analyses. This beautiful review, published in 2022, included studies describing exome results in pregnancies with short long bones and/or IUGR with ruled out aneuploid. The review included 116 pregnancies with IUGR. In 70 cases with isolated IUGR and evidence of placental insufficiency, the incremental yield of prenatal sequencing over CMA or karyotyping was not statistically significant. The authors noted that the numbers of cases in this cohort might be too small to draw any firm conclusions. In the cohort of non-isolated IUGR, a substantial incremental yield over CMA was noted, although the number of cases was 48. Short long bones, whether isolated or non-isolated, were associated with a significantly increased pooled incremental yield. The second important review on this issue was published in 2023 by Pauta and Borrell. These authors focused only on studies examining the yield of exome sequencing in isolated IUGR. You can see that the included studies differed in the definition of IUGR. Okay. Of the 146 fetuses, 17 abnormal findings were noted, yielding a significant 12% incremental performance pool of exome sequencing. The authors noted that the vast majority of these cases were studied before 20 weeks of pregnancy, meaning early onset IUGR. Unfortunately, I didn't find any studies exploring the yield of genome sequencing in pregnancies with IUGR, but I suppose this will show up in the near future. What are the professional guidelines saying? I'm presenting here only several guidelines. Please note how the definition of IUGR differs from 10th percentile for fetal weight or abdomen, 3rd centile for fetal weight or other. In most guidelines, invasive testing is recommended only in the presence of fetal malformations or polyhydramnios, or in early onset IUGR, mostly defined as 32 weeks. Some noted even earlier gestational age of 23 to 24 weeks, and some required ruling out signs of placental insufficiency. Regarding the recommended genetic testing, most recommended chromosomal microarray analysis. So it seems that there is still no evidence to recommend amniocentesis in pregnancies with late onset isolated IUGR. The take-home messages are: First, the risk of genetic disorders in fetuses with isolated late-onset IUGR remains inadequately defined. It seems that there is enough evidence to support recommendation for prenatal invasive testing in pregnancies with non-isolated IUGR. Thus, a detailed sonographic evaluation should be performed in all pregnancies with IUGR to rule out sonographic anomalies with an emphasis on cardiac defects. In addition, invasive testing should be considered in early onset IUGR and in severe IUGR. Finally, effort should be made to continue exploring this common and important issue. I thank you very much for your attention and will be happy to answer some questions.